this is very interesting meeting. EHA is becoming more popular and many more doctors are coming. And now we have, as a reflection of our interest in myeloproliferative neoplasms, many more sessions, oral sessions, on new developments in myeloproliferative neoplasms. So the sessions on biology are dissecting the causes of hyperactive JAK-STAT pathway. Hyperactive JAK-STAT pathway is the pathway inside the bone marrow cells that make cells active all the time. This is cascade of proteins that make cells grow. And that is abnormal and it's active all the time in myeloproliferative neoplasms. But it's not very easy to explain why is that. We know about the JAK2 mutation, we know about calreticulin mutation, MPL mutation. These are funny names of different mutations that lead to activation of this cascade of proteins, the JAK-STAT pathway. But how and why does it happen, and what's the role of other genetic abnormalities that we became aware of in these cells in the bone marrow patients? That is the major talk. Overarching understanding of that particular problem is the theme of the biological sections here at EHA. When we cross over to the clinical parts, there are two aspects here. The one is prognostication and understanding what these mutations that we can identify, and we try to understand what they do. But what these mutations actually predispose patients to have in their own life. Is it increased risk of thrombosis in patients with polycythemia vera, as we mentioned before, or ET? Or is it a transformation to acute myeloid leukemia? Or is it something else that make people have a different outlook and outcome when they live with the disease based on their genetic background in those cells in the bone marrow? So a number of such talks have been presented here. On the clinical part, in terms of clinical studies, one particular study I'd like to highlight. This is a complementary study to or earlier study from a year ago that led to approval of Ruxolitinib, a JAK inhibitor for polycythemia vera in second line. This is a study presented by Dr. Passamonti called Response 2 study that accrued patients with polycythemia that were not doing well or resistant refractory to hydroxyurea that did not have a big spleen. Many patients in this situation do have a big spleen. That was the goal of the first initial so-called response study that led to approval of Ruxolitinib. Now, complementary study in patients without the big spleen was done. And again, the patients did very well on Ruxolitinib, improved their blood cell count, decreased the symptoms, and it appears to perhaps even decrease the thrombotic risk. So the two studies now, the earlier one that I have led and Dr. Passamonti study now certainly cement that knowledge and the clinical activity of Ruxolitinib as a second-line therapy in PV.